with the accessories inside and ready to use. You should have, hopefully, a member of staff who weekly, at least at the minimum, checks all the kit to make sure it's in date and is ready to use there. Within that kit, you should have a range of oxygen masks. Often when I go to practices, what I tend to find is there will be one mask out of its packaging and discoloured yellow often, and a bit of tube in there that's normally tied in a knot, and that's the mask that's probably been used between a number of patients. Now I remember some 20 years ago when I first joined the ambulance service, all our mask was you just reused it, you washed it, give a quick wipe around with the patient, put it back in the box for the next one. We have moved on, and in your kit you will need at least 2 minimum adult masks and then 2 minimum paediatric masks. And there is what we call a low oxygen content mask, at 28% should be in there, and you should have what we call a trawl mask, or 98% mask for patients who are severely short of breath. So you should have a range of oxygen therapy masks ready in sealed bags. Now we move on to oropharyngeal airways, OP airways. Here's another challenge for the dental practice. Often when I go around, and in fact to be quite honest with you, I'm not sure if I've ever found any dental practice yet who's actually used an OP airway. And there's a challenge within the training, because as healthcare professionals, as you'll see in a moment, you need to know how to use a bag and mask for resuscitation, and ideally you should always be using an OP airway. So within the training, it's very important that your provider can help you apply them skills if in the event you need to use them. Now there should be a range, and as you can see there, it goes from 0 to 0 right up to the number 4. I personally advocate in the dental practice that you just stick to them sizes there, which is 2, 3 and a 4 for adults only. For the rest of them, they're for paediatrics. And if you're ever dealing with a paediatric emergency, a child who's unconscious, I'm a great believer in good basic airway management with the child, because your adrenaline level and anxiety is going to be sky high. And the thought of you having to put one of these airways into a child when it comes to it is rather daunting, okay? So I often advocate keep to the adult sizes. Bag valve mask. Here's the next challenge for the dental practice. There should be in the kit a bag valve mask for the use of mouth-to-mouth ventilations. Now, the good news is, as we move along in resuscitation, we are moving away from mouth-to-mouth resuscitation, and we're very heavily sticking with chest compressions. Down here in the South East Coast Ambulance Service, we are the only ambulance service that have what we call Protocol C, which is very much about chest compressions, and more chest compressions when it comes to cardiac arrest. Now, as a healthcare provider, you will be expected to know how to use a bag valve mask in the event of a cardiac arrest. And your team will be expected to know about chest compressions, eventually working to 30 to 32 ventilations. Now, the challenge with the bag and mask is, even paramedics, when they initially train, etc., spend 4 weeks with a consultant in theatres learning how to use them correctly. If used incorrectly, you can actually cause problems. So when it comes to it, your provider should be trying to help you understand how to use the bag and mask, when to use it, how to use it appropriately. And hopefully the emphasis should be very much on chest compressions when and if you ever have to deal with a cardiac arrest. That's where you have no breathing and no heartbeat at all. But it should be there. And you need an adult size and a paediatric size. So there should be 1 adult, 1 child in a sealed bag and ready to use if it comes to it. Moving on a bit, we have a suction pump. Now, within your resuscitation bag at the top there should be a manual resuscitation pump. Now, we know when you're in your dental chair there you have an automatic one, thank goodness. However, if someone was to catch just outside your practice, in the practice waiting area, if the airways are occluded when we're talking about vomit, etc., and many patients to go unconscious, do vomit, you need a manual suction pump. Now, is there anyone here who's ever tried to use a manual suction pump? No? Take it from me, they're not particularly good. They're really not. In short, I believe it ticks the box, and I've tried to use manual suction many a time with patients, and it's a great challenge. It really is. They don't suction very well at all. Especially that one. And that one there you can find in most catalogues for about £25–30, and I think that probably just about sums it up, because anything, you get what you pay for at the end of the day. The professional ones we use in the ambulance are around £130, and you do get some suction there, and it works reasonably well, but if the person has vomited and consistency is rather thick, you're back to good basic airway management again, and that's what we mustn't sacrifice, we really mustn't. So it should be there, limited use I have to say, but it's a requirement. The AED, we just heard a little bit about that, and so that should be in the practice. Many practices, I have to say, I've only had a phone call this week, another practice I deal with, Sun Hill and Hope, just required an AED. It's cost, isn't it? It's what's the cost, and you've got to weigh up the risk, etc. All I can say is the work I've done with defibrillators, more and more the pressure's building up, the waves as it were, and people are really starting to wake up to the benefits of having an AED. I mean, if you only go back 5 years ago, 6 years ago, you may have been paying around £3,500–4,000 for a defibrillator, and many people were very worried about using them. What if I kill someone? Well, no, the idea is to save them. They're actually, if you're using an AED, technically you could say they're deceased, and you've literally got 5 minutes generally to try and turn it round. So AED, ideal, and I personally, because I deal with this stuff all the time, I would try and advocate where you can afford one, look at venturing out and purchasing one. Blood sugar monitor. So in your kit there should be a glucose monitor for when dealing with patients with suspected hypoglycemic attacks. Now, once again, this is an area that I constantly, personally advocate. Yes, it needs to be in the kit. It will tick your boxes regards GDC and Care Quality Commission. The reality is, will you ever use it? I don't think that should get in the way of basic good first aid. Someone in your practice who's missed their breakfast, they're a diabetic, they sit in the chair, all of a sudden they get a bit lightheaded and a bit sweaty, you realise they're diabetic. Just good first aid, sugary water, Lucasade, a bit of coke there to bring them round will be absolutely fine. Many practices when I go, your training provider should be showing you how to use them and teaching you, but most of the dentists I go to, they shy away like mad for using one. And in fact, the practice was that last week, said, we tried to use it, Gary, we had a diabetic and we got in such a pickle with it. And it's something as simple as the lancets where you just twist off the top and then push it into the finger. They couldn't work out how to twist the top off. When I showed them, they were, oh, don't believe it. I don't blame them. They don't do it every day of the week. It's not their cup of tea. But once again, I think the training should be, again, with good basic first aid, recognising the hypoglycemic attack rather than going unconscious when they have to be into this area. But if you're a practice in the middle of nowhere, of course, up in the Highlands somewhere, different story. You may have a half an hour, 40 minutes, an hour before an ambulance turns up, so you would have a duty of care to go into that area. Syringes. Now, I put syringes there, folks, because every time I open up emergency kit in a dental practice, they tend to be filled with 20mm syringes, 10mm syringes, 5mm syringes, and then you say, what are them syringes for? Because most of all your drugs now, you won't need a syringe. However, we just touched on adrenaline, 1 in 1,000, which we will do shortly. One of the biggest, personally I advocate, one of the things you should have is the 1mm syringe. And that always seems to be missing. A 1mm syringe ready with a draw-up needle, 1 in 1,000 adrenaline. Because in your 1 in 1,000 adrenaline will be 1 ml of fluid. And your 1 ml syringe, you just draw up your adrenaline and you're ready to treat anaphylaxis. And anaphylaxis in the dental world at the moment, there's been a couple of high-profile cases, and recently one in Brighton. Only 2 months ago at practice, I deal with another anaphylactic shock, and I've always advocated you keep your adrenaline and your 1 ml syringe together, so in the event of that emergency, there's your kit. Snap the ampoule, draw up the medicine, and away you go. So reconsider whether in an emergency kit, do you really need cannulas? Very few dental practices cannulate these days. So if you've got needles and things that shouldn't or do not need to be in there, move them out, because when that emergency happens, they'll be in your way. You'll be picking out everything you need apart from what you actually need. And then a spacer. This one is often forgotten in the dental practice. There should be a spacer there for if you have a patient who has breathing difficulties, or a child, or of course someone who may have learning disabilities, to help them take a Ventolin as part of your treatment for shortness of breath, maybe asthma, wheezing, etc. That is your basic medical kit that should be ready, sealed, checked weekly, ticked off on the list, ready to go. And you should, as a medical practice, everyone should know where it is, not locked away in the cupboard that you're running around asking for keys, or who's seen it, where is it. And don't just give it to one person. Often people say, oh, that's down to Julie to do, but Julie's been on holiday for a week or two, or she's been ill, so no one's checked it. The more people you make responsible or take it to terms, the more they're likely to get used to seeing the equipment, feeling it, knowing how to turn it on and off, etc. So when it happens as a team, you've got a lot more people used to seeing the equipment rather than just one person who knows about it. Let's just